Welcome, everybody, to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am your host, Aaron Fine, the Social Media Marketing Coordinator, and I'm joined by the wonderful Cherie Binns, who's joining us today to answer your MS-related symptom management questions. Now, I'd like to introduce Cherie to those joining us for the first time. Cherie Binns is an MS certified registered nurse and serves as the patient healthcare liaison for MS Focus. Cherie was diagnosed with relapsing remitting MS in 1994 and was found that adopting some changes in her lifestyle has made her MS much easier to manage. We are pleased to have her join us today. Cherie, as always, thank you for being with us. And I'll turn it over to you as soon as I tell everyone how to submit their questions. So as everyone knows, this is a Q&A virtual webinar presentation. If you have a question or comment, you can ask it during the Q&A using the Q&A button in the app, which also allows you to send your question anonymously if you choose. We kindly request that you direct your questions to the Q&A section and refrain from posting them in the chat area. Again, put everything that you want to ask Cherie in the Q&A section and refrain from posting in the chat area. You could obviously utilize the chat area to speak amongst yourselves, but for all the questions and all intents and purposes, it's much easier for us to be able to provide Cherie with the questions if you do it in the Q&A section. If you'd like to ask your question live, click the raise hand button or press *9 if you're on the phone. I'll call on you and then you'll unmute to ask your question. So without further ado, welcome to Ask the MS Nurse with Cherie Binns. Cherie, I'll leave it to you. Thank you so much. And we'll start getting these questions ready for you. Let's see what we got for you. Okay.
We'll tell those while Aaron's getting the first question. The raise hand on my computer, at least, is not immediately visible. It's in the react emoji at the bottom of your screen, at bottom center of your screen. So when you click on react, there's a raise hand button if you need to ask your question personally.
All right, well, we are ready to go. Our first question of the day, Cherie, is from Nanette, and she wants to know, how does estrogen improve MS?
Oh, wow. What a timely question. I recently did a webinar with Dr. Gretchen Hawley for the Missing Link on the impact of hormones on MS. I can send you the link to that webinar if you'd like. You can email me at cherie@msfocus.org and I will send that link to you. Or I don't know if Aaron has the link and can pop it into the chat for people that want it.
Well, I can certainly get that, yeah, during this program. I'll throw that in there.
So what we now know basically through years of observation is that women with MS have often reported that when they get sort of halfway through their cycle, their MS symptoms start to get a little bit worse. And when they get to within a week or so of the time that their period is going to start, they often develop something called PMS or premenstrual syndrome, where they're irritable, they're bloating, they're headachy. They just feel like crap. And that's because your estrogen levels have dipped. And once you've had your period and the estrogen levels start recovering, you're starting to feel better. We also now know that when a woman enters perimenopause, that maybe 5 to 10 years prior to actually stopping their periods, average start of time for that is right around 41 or 42 years old for most women. Actually, there's a slight difference. I recently heard a talk on this where it said that Women of African descent will sometimes start that process around 37 or 38, where women that are Caucasian may, on average, start at around 41 or 42. So there may be a little ethnic difference with that. And I don't know why that would be. It doesn't make sense to me that there would be, unless it maybe is dietarily mediated. I'm not sure. But what we're finding now is that our MS symptoms tend to worsen when we get into that perimenopausal age, above the age of 40. Let me just pick that as a date. And our spasticity may worsen, our vision may worsen, our fatigue may seem worse. Um, and we often find that giving an individual a little hormone replacement therapy will alleviate not only those symptoms, but it'll also improve the overall sense of well-being. So in a nutshell, that's kind of the impact of estrogen. There are also other female hormones that may impact that. And I will tell you that next month on the 7th at 3 p.m. in the afternoon, May 7th at 3 p.m., we're going to be doing a webinar solely based on the impact of hormones on women living with MS.
Okay, wonderful. That was a lot of great information, Cherie. Thank you so much. So, Nanette has a follow-up question. Can Veoza help with heat intolerance? Are you familiar with
Veoza.
Veoza? And
I'm
she has it spelled Beozah. So that might not specifically be the correct pronunciation or spelling, but are you aware of what she's talking about?
I'm not. I'm not.
Okay, Nanette, if you want to kind of give a little bit more context into what you are asking about, please put it in the Q&A and we'll get back to you. Awesome. All right, we will keep moving this along. Someone would like to know, why am I having cognitive decline without any new lesions?
Cognitive decline with people with MS is very common. Oftentimes, it's one of the first symptoms of MS. So, decline without any additional changes can happen oftentimes as we age much more rapidly than it would happen in our counterparts who are the same age. MS tends to cause some brain atrophy in many people. So the cognitive decline could be related to that. I'd strongly recommend getting neuropsych testing done as a baseline if you're noticing cognitive decline. Some things can be targeted on those tests. I found it extremely helpful when I had my first set of testing done back in 1996. They identified specific areas that I could work on I worked with a speech therapist who treats cognitive decline in people with MS, and got some very, very helpful tips that allowed me to stay in the workforce almost 2 years longer than I would have otherwise. So, and I see that Erin has ticked different websites into the chat where you can listen to that podcast on MS and menopause. It was directly related to menopause and how MS is affected by that.
Okay, so Nanette did write back. It's still the same, it's still the same spelling, and but Veoza is for menopause hot flashes. Can this help with heat intolerance?
Uh,
If you
Probably not.
okay.
I would say that heat intolerant, you're going to be having more heat intolerance once you hit that menopause stage and start having hot flashes. It may be considerably worse until you can get those under control, but certainly the cooling products that we use to help manage our heat intolerance can be very helpful during that time as well. And I will say that our cooling program is only running for another about a month and a half, at
Mhm.
almost 2 months actually. It ends June 1st. So we do have an application for cooling products on our website, msfocus.org. Get that application in. We can provide either a cooling vest and scarf or cooling accessories for you if you qualify for that program.
It's true. And I'll also put the link for the cooling program in the chat in 1 second. But first, I want to get to Carol's question. Cherie, Carol asks, how can you make sure your bladder is empty without using a catheter?
Um, in the talk that I gave last month on neglected MS symptoms, I talked about bladder size. The normal size of a bladder is about 1 cup of urine, or about the size of an open fist, like this. If you have that's about 250 cc's, or 1 cup of urine. The average woman, Carol, I'm assuming Carol is a female, the average female voids about 15 cc's a second. So once the stream starts, you can count off the seconds or time it on your watch. 1,000, 2, 1,000, and multiply that number of seconds by 15 and get the amount of urine approximated that you have voided. So if your flow is only for 10 seconds, that's 150 cc's. So you may have another 100 cc's left in the bladder. If you just sit there for a minute and don't get up right away, and then just take a couple of deep breaths and relax and try to empty the bladder more fully, that if you're letting more urine go during that time, then you know you're probably not emptying your bladder fully at the same time. If you're getting urinary tract infections on a regular basis, oftentimes that's because the bladder's not fully emptied, and it's the urine is becoming infected because it's not getting out of there. Normally urine is sterile. And so when it sits on top of itself like that, there is a chance of a urinary tract infection. They can do a bladder scan when you're in the doctor's office, particularly the urologist's office, to see how much urine is left in your bladder. If it's under 50 cc's, we're not too worried, but if it's 100 or higher, then we may suggest that you try a catheter for a bit. I used to use them. I don't need to use them anymore. So once you go to a catheter, it doesn't mean you're always going to be using them.
Okay, that's great advice. So someone would like to know, do you have any tips or suggestions on how to reduce the chances of passing MS to your children? Good question.
Um, you if you have a child and there is a genetic propensity, you can't change that except by certain things like adding vitamin D. Um, Most children as infants should be getting vitamin D supplementation in their formula. If you're taking vitamin D and you're breastfeeding, they're getting some passed through with the breast milk. Vitamin D supplementation for young children to the tune of 100 to 400 international units a day is often recommended. Talk to your pediatrician and see if they would, with you having MS, if they might want to recommend a higher level. However, it's good to note if you're supplementing vitamin D that D can be toxic. So there is a vitamin D toxicity that can develop, and it looks oftentimes like a severe gastroenteritis, like vomiting and diarrhea. Vitamin D is not peed out like the water-soluble vitamins, so it can build up in the fat cells in your system and cause problems that way. So I would say if you're going to be giving your children vitamin D, make sure their pediatrician's checking their levels at least once a year, even every 6 months, if they're on a higher supplementation of that.
Okay. Hopefully that answered your question in some capacity. So someone would like to know, and I'm going to reword what they're saying, so maybe it's a little easier to understand. So basically, this individual would like to know, how can you separate whether or not you're having symptoms due to just age, or are these symptoms specifically correlated to MS?
Okay. Um, It's kind of like the mother of all questions. Is this age or is this MS? By the time any of us starts to hit around 50, we're starting to slow down a little bit. We're starting to have some aches and pains, particularly when it starts to rain, just because of like wear and tear on our joints. If you're a runner, you may feel that even more frequently than if you're not. We may need more sleep, or we may have interrupted sleep patterns. Our bladder emptying, male or female, may get more frequent, so that we have to get up at least once during the night, which often adds to the fatigue that we're feeling. So I would say if you're healthy, if you're eating a good diet, if you're getting a good amount of activity in your day throughout the day, and these things are still happening, it's probably wise to bring that information to your neurologist, have them check it out with a follow-up MRI, and treat it in whatever way they feel is necessary. But oftentimes, as we reach our 50s, aging and MS sort of intersect with each other in symptoms.
Hmm. Okay. Yeah, that makes a lot of sense. So somebody would like to know, what are the advantages or disadvantages of either, I'm going to pronounce it baclofen. Cherie, is it baclofen or is it baclofen?
Clothin. Yep. All right.
Okay.
One
Or
of
no,
the
the other one was tizanidine.
Tizanidine is also known as Xanaflex.
Hmm.
They're both drugs that we use to manage spasticity, which is muscle tightening, muscle tension. For many of us, we are in a constant state of muscle tension and need to really stretch out on a regular basis to help that. I personally prefer the tizanidine or Xanaflex because I can take it as needed. So if I have a lot of spasticity, for me, it's in my uh, left leg and hip. And that will often wake me up multiple times at night with cramping, with pain. Um, and if I can take a little bit of tizanidine before bed, it not only helps me sleep, but it does relax that spasticity, so I'm not in as much pain. Um, Taking that particular drug during the daytime adds a lot of sleepiness. Baclofen needs to be taken on a regular basis to build up blood levels so that you have a therapeutic blood level that keeps that spasticity at bay. It doesn't necessarily take it all away, but it keeps it calmed, sometimes to a dull roar, but even less than that a lot of the time. But it can interfere with your level of alertness, and it can cause some cognitive fog. So for that reason, if your spasticity is something that is interfering drastically with your quality of life, you might need baclofen, but if it's not, then tizanidine might do the job for you. And you can add tizanidine to the baclofen at bedtime as an adjunct to it if the spasticity is keeping you awake at night.
Hmm. Now, Cherie, you mentioned they're both for spasticity. I always get this wrong. Spasticity, correct?
Yep. Yep.
Okay, copy that.
Yep.
Nanette, I see you have another question. We are going to get back to you. We're going to get to somebody else who hasn't asked one yet, but I promise you that's a great question. We'll get right to it in a second. Somebody would like to know, can UTIs be a result of muscle relaxants or mostly MS related?
MS related. I doubt that they're related to muscle relaxants. The muscle relaxants that you use for MS, the antispasticity meds, which we just talked about, don't work on the smooth muscle of the bladder. So they work on the more striated muscles, such as the muscles in your legs. Um, so it would not make a lot of sense that it would cause a UTI.
Okay. Um, this is more of just a comment, and if you have anything you want to add to that, Cherie, go ahead. So this individual just wanted to say, I was tested with a speech therapist, but it was mild. However, my job was in emergency services. highly stressful and horrible hours. I was fine for 10 years, but was affected by a call and am now in the disability process.
Okay. Um, the speech therapists don't usually do that neuropsych testing. Um, so you would need to have that done by a neuropsychologist. And then they might refer you to a speech therapist to help with the cognitive retraining. I'm sorry that it's progressed to the point where disability is now on in the forefront. I've been there. I understand how frustrating it is. Uh, I also, that was years ago before we had some of our more effective medications available. And once they became available to me, um, that made a big difference. And I was able to sort of modify what I was doing to get back into the workforce. So I hope you're able to do something similar.
Mhm. Yeah, I hope things get a little bit better for you soon. So we're going to go back to Nanette. She would like to know, can low dose naltrexone help with MS?
Certainly seems to help with a lot of the symptoms for particularly people who have secondary progressive forms of MS, for whom maybe a disease modifying therapy is no longer working. Um, it it tends to improve mood in just about everybody that's taking it. And with the improvement in mood, it seems like the other symptoms just sort of start to melt away. I haven't met too many people that have taken it that are really dissatisfied with it. Um, I am extremely sensitive to some medications, and even at the lowest dose of low dose naltrexone, after a little over a week of taking it, I was like wide awake. I couldn't sleep anymore. And it took me about 3 weeks after stopping it, after only being on it for a week before I kind of normalized my sleep pattern. So just be aware if you've got too much energy. They want you to take it between 9 p.m. and 3 a.m. Those were the directions that I got. And when I talked to my neurologist about that, he said, you know, I know that that's what they say, but I've got somebody who takes it between 6 a.m. and 3 p.m. and they are doing fine with it and they had problems with it. So you may need to adjust the timing of your dose. But it's not a disease modifying therapy, but it does seem to improve symptom perception.
Hmm. Now, Cherie, forgive me if you've already kind of answered this, but specifically for that time window, is that because it might cause fatigue?
No, actually, it's the opposite. Um,
Okay,
it
really?
actually, people that are on it report that their fatigue is really, really improved. And it doesn't take long. It takes maybe 3 or 4 days to for a lot of people to start noticing some improvement in the intensity of their symptoms. So I'm not sure why, but those were the directions that came from the compounding pharmacy for me. It is not covered by insurance. It has to be compounded. Um, just a little background on LDN or low dose naltrexone. It is a drug that came to us from the addiction treatment arena. Naltrexone, naloxone, they're similar drugs. So if you're taking that type of drug, that class of drug, you may not be able to um, consume alcohol. It may make it more difficult. You may not tolerate the alcohol as well or get an impact with way less than you would normally have. So it's a kind of a deterrent to drinking. It's also if you're taking something like Vicodin or Percocet or anything like that for pain, it's going to nullify the effects of that drug. So you need to sort of weigh the cost benefit if those are things that you're using on a regular basis and for one reason or another can't stop their use or minimize their use. It's not a one or it's a one or the other. It's not a let's find a happy medium and try both.
Oh man, that's really interesting. Thank you for explaining that. Someone would like to know, I am feeling pain and heaviness in my right leg. Would Motrin help with that type of pain?
If it's heaviness, my guess is it's related to spasticity. And stretching could help that. Motrin could, certainly. Tylenol could. I wouldn't take anything much stronger than Motrin for that. And if it persists for longer than 2 or 3 weeks with the Motrin, I would certainly bring it to the attention of your doctor.
Hmm. Okay. Someone would like to know, is it possible for lesions to decrease on MRIs, and how does this happen?
Yeah, it is. It's very possible. Um, Dr. Akuda last year at the Consortium of MS Centers annual meeting showed us several before and after or original and then follow-up MRIs, and the size of the lesions were often smaller. They were I've seen MRIs where people had 30 or 40 lesions on one MRI point that weren't enhanced, but the lesions were still there, and you could see the spots on the MRI. And a year later, you were only seeing 13 to 15. That's not to say that the lesions all disappear over time if your MS is well treated, but certainly they do decrease in size or the ability to see them really clearly without magnification.
Tanisha from Facebook asks, can you tell me about Copaxone?
Sure. Copaxone was one of our original, what we call platform drugs. It is an injectable. It used to be a daily injectable, and now we've got it, now it's available for 3 time a week dosing. It is four amino acids that are put together to sort of protect the central nervous system. It is one drug that tends to cross the blood-brain barrier to sort of wrap around, for in simplistic ways, to sort of wrap around that nerve to protect it from things trying to attack the nerve. Um, it it tends to be one of, considering what we have available now to treat MS, it's one of the less effective drugs, but it is often used for those of us who are aging and maybe don't need something quite as effective anymore because our immune system has calmed down. So it's often recommended for people over the age of 50 who have a more stable form of MS, not on new diagnosis at age 50. We want to try something a little more effective then. But if you've had MS for years and your MS has calmed down, that might be something that's recommended at the end. I certainly would not give it to somebody who is newly diagnosed and in their 20s
Hmm,
because we have something so much more effective that can help you right now.
that's a good point. Um, Someone would like to know, any suggestions for someone with MS with hormone positive breast cancer?
Again, your oncologist is going to be helpful for you with that, but I think you can probably take some of the oral medications. The B cell medications, maybe not. Um, and certainly that would be someone who might be a candidate for Copaxone.
Hmm,
So, because it doesn't really impact the immune system other than to protect the nerves from being more damaged.
okay. Hopefully that answered your question. So someone else would like to know, how much vitamin D should someone with MS have daily?
It depends on your blood levels.
Mhm.
If you're supplementing vitamin D, if you're taking vitamin D, you need to have your vitamin D levels checked at least twice a year. The recommendation for up until like 2 to 3 years ago was that we keep our levels somewhere around 60 or above. Um, the normal level is 30 to 100. And so they wanted it kind of in the mid range, 50 or 60. At the Consortium of MS Centers annual meeting 2 years ago, they came in and they said, we've done an analysis of multiple studies on vitamin D. We really felt like it protects the central nervous system. It protects the nerves from damage. There are lower levels in vitamin D as a rule in people with MS than in people that don't have MS. Um, and so we expected to see supplementation really protect the nerves, and we're not seeing that. And we don't know why. And they were looking at literally, 100 different studies and the reports on the studies, and they weren't seeing a great deal of improvement once people had developed MS. So their new recommendation to prevent toxicity was to keep your vitamin D levels between 35 and 50 and not to try to keep it at that higher level. So most people can do that by taking 3,000 to 5,000 units a day. They are recommending that you not exceed 50,000 units per week.
All right. We have another catheter type question, Cherie. So someone would like to know, well, they first want to let you know that they self-cath, but unfortunately they get UTIs quite often. Do you have any tips on how to make that not be such a thing?
If you're getting frequent UTIs and you're catheterizing 4 to 6 times a day, which most people that are self-cathing do, it might be a matter of your technique. Wash your hands thoroughly with soap and water. Use a clean washcloth each time to clean the area that you're around the urethra so that you're not transferring bacteria from right around the urethra into the bladder. Make sure that the catheter doesn't touch anything before getting to that hole. Um, and just be sure that you're not picking up contaminants from other places.
Very important.
Your doctor also might order something that is a prophylactic low dose antibiotic, something like macrodantin, maybe a daily dose of macrodantin, low, very, very low dose of antibiotic to just keep the bacteria level low.
That's something that they could take daily?
Mhm.
Oh, interesting. Okay. Cherie, we have our first person with their hand raised. I'm gonna let them, I'm gonna allow them to speak and they can ask you their question directly. All right, let's let.
Is it Machika?
Yes, that's right. Often it's mispronounced, but thank you very much for answering our questions today. Everything that you've indicated so far or answered so far has really been quite a bit of a help for me, and I'm sure for all the others that have joined today. The Consortium of Multiple Sclerosis, do they not have a website? Where
They
we
do.
okay, can you perhaps add that to the chat?
Yes, it's mscare.org.
Okay, MSK. I'll just make a note of that. And then my next question is, what is your advice for physical therapy it in an area where it's hard to find therapists that are multiple sclerosis certified, or even neurological certified? Is there a website where you can find those individuals in your particular area or region?
Actually, Dr. Herb Karpatkin, who
Oh,
is our physical therapist,
uh-huh.
says that any patient that is calling into our webinars can be given his email. So maybe Bhavya, if you would look up Dr. Karpatkin's email and pop it into the chat for Machika. He has a network of 1,000 or so physical therapists around the country who have special training in working with people with MS. I think it's Herb KPT at gmail.com, something like that, or Carpat, Herb Carpat,
Okay.
Hearpat. Is it at gmail.com? I don't know. Anyway, Bhavya, could you look that up and pop that into the chat for Dr. Karpatkin so that Machika's got that. And he said if you email him, tell him where you live, he will get back to you and let you know who in your area might be helpful. I don't have anybody here where I live. I would have to drive about 45 miles
Oh,
to go to physical therapy. And I'm getting to an age where I don't like to drive in the city anymore. So driving to Providence is not on my bucket list. I do have found a physical therapist that's just a block and a half from my house who really has gotten some extra training. It's basically you don't want to work the same muscle group over and over and over again. You want to like you don't want to be doing your 10 reps of something while you're with the physical therapist because it can tire that muscle group. So you want to go from muscle group to another and then back if need be. I also make it a point when I'm going in for physical therapy to say, show me what you want me to do. I will demonstrate it to you so that you know that I'm doing it correctly, but we're not going to do any reps of exercises while I'm here so that I've got enough energy to get home. They'll send you home with a written list with diagrams of what to do exercise wise, and you can kind of split it up throughout the day.
that's a great point. Thank you for mentioning that. I had not thought to do that because often after an hour or 45 minutes of physical therapy,
Yeah.
I'm exhausted.
You're wrung out. I
Or I'm
remember,
run out of the ability to get in my car and then
yeah,
make myself able to get home. I have a handicap controls in my car. So that's a great point. To that I'm glad you brought that up, and I hope that everyone else can understand that as a possibility to redesign your PT program. So thank you so much for sharing.
thank you, Machika. That was an important topic.
Thank you, Machika. That was wonderful. All right. Let's get back to it. So next individual will like to know, can you take oxybutynin and mirbitrek, hopefully I'm pronouncing that correct, to help frequency?
Yes.
Okay,
Yep.
easy enough. Let's keep moving. Can baclofen cause your legs to be weaker and make walking harder? Or is it baclofen?
Baclofen.
Baclofen.
Yes, it
Okay.
can make your legs weaker. You don't want to overdose those drugs because you do need some tension in those muscles to keep your frame upright. Um, there are people who tend to get a little bit snowed and not have the real good results that they want for spasticity by taking oral baclofen. The maximum dose that you could be taking, and this would have me practically in a coma, would be like 40 milligrams 3 times a day. 20 is about what we'd like to see as top, but I know that there are people out there taking 40. When you're getting that high, you probably are going to want to have a conversation with your doctor about putting in a baclofen pump. The baclofen pump is something that is inserted under the skin of the abdomen. It's about the shape of a hockey puck, but a little bit smaller, and it's pre-filled with baclofen, and it can be refilled in the office every couple or 3 months. In fact, there are no companies that'll come to your home to refill it just by injecting more baclofen into it. The setting for how much is given to you is very, very tiny. It might be 1/100th of the dose you're getting orally, but it's going straight into the central nervous system. So there's a little catheter that's fed into the space between the vertebra in your back, and it just gives a tiny amount of baclofen that bathes the spinal cord and brain. It gets into the nervous system, so it needs very little, and you don't get the side effects of cog fog and fatigue that you do with the oral baclofen.
Mhm. Okay, wonderful. So somebody would like to know, my MRIs are stable, but MS symptoms are worse, mostly walking. Should I possibly switch my DMT?
That's certainly a question for your neurologist. I don't know what DMT you're on, but if you're taking one of the older injectables, it might be that that's the problem. I don't know what age you are, but after 50, 55, you may begin to have more problem walking. So it is age dependent. It is dependent upon your MRIs. It's dependent upon whatever disease modifying therapy you're on. So um, I can't say that I can answer the question as asked.
Fair enough. If you have any more information that you'd like to provide for Cherie, please put it back in the Q&A box, and we'll get back and try hopefully answer your question as best as Cherie can. Brett was diagnosed with MS 6 months ago. Sorry, Brett. Initially, I experienced numbness in approximately 60% of my body. I underwent a 10-day treatment with is it a char or a Achar?
Acthar.
Acthar. Excuse me, I missed that. You know what? I'm learning as we're going.
That's
Missed that.
okay.
So yeah, please let me know if I'm mispronouncing it. So he had those injections, which successfully reduced the numbness to around 20% over several weeks. However, the numbness has started to return, and I'm particularly concerned about the sensation in the groin area. Are there any additional treatments or strategies that could help alleviate the numbness? Thank you for your guidance.
Okay, Acthar gel is something very similar to a steroid. It's not a steroid, but it's very similar to it. So its job is to reduce inflammation. And the inflammation could be causing a pinching of the nerve and the numbness that you're talking about, or it could be causing a pinching of a nerve with stabbing nerve pain. And just calming that down is the goal of this. There is nothing particular that will take care of the numbness. Acthar gel should not be used longer than 10 days to 14 days because it's just that's as long as you need to treat this, and you don't want the side effects, long-term side effects that you'd get with a steroid, which you often also would get with the Acthar. So it's really not a treatment that you can do long term.
So Cherie, Brett has responded with a little bit more context. Let him know if this helps in any way. He says that he's 57 and he's on Zeposia.
All right, so 57 in Zeposia, you might want to go up to something like Tysabri or one of the B cell depletion medications. If you're, 57 is really the time frame when you're going to start having some more problem anyway. So my recommendation might be that you start seeing a physical therapist and maybe get into a strengthening program so that you can improve your gait. I do that at least once or twice a year because I don't see from my perspective that I'm getting a little worse until I trip over something or until I misstep and end up on the ground. So um, it does behoove you to get a physical therapist's eyes on it, and maybe they can give you some tips on your gait that would save some energy and help the walking to improve.
Okay. Sir, I hope that was helpful, and I hope you start feeling better. So someone would like to know, my neurologist nurses tizanidine can sometimes make you feel like you're burning when urinating, or like if you have like a UTI. Cherie, have you heard of this?
No, just never heard of it.
Okay.
And I've been on tizanidine off and on for about 30 years now. I've never experienced that. Um, I don't think the nurse knows what they're talking about.
Yeah, you gotta you gotta start at the beginning, I guess. Hopefully you feel better. That's not fun. While taking Ocrevus, do I still have to be careful when I get flu shots and other vaccines?
Back when COVID first started, we knew that the B cell depletion medications like Ocrevus tended to blunt our vaccine response. So we wanted people to get as much benefit as possible out of their vaccine. So we recommended that they get it in the month prior to their infusion so that their levels would hopefully be dipping. We now know that people who have been on this class of drugs, whether it's Ocrevus, Rituxan, Briumvi, Kesimpta, um, once we've been on that drug for a year or more, we don't drop those levels. It takes us a good 9 to 12 months to drop those levels once we've been on them for a year or two. So at this point, you can get your vaccines at any point in time. Um, and they may not be overly helpful if you've been on this class of drugs for very long, but there's really not a timing issue right now.
Okay, Cherie, we have another Ocrevus question. So this individual has breast cancer in their family. Is this not a good DMT to try because of that?
When Ocrevus first came on the market, it came out with, it wasn't a warning as much as it was an observation that there were, I'm thinking, as I'm seeing it in my mind's eye, I'm thinking that there were maybe four cases per thousand of people um, that were not on Ocrevus or that class of drug that were getting breast cancer. And there were 5 cases per thousand in the Ocrevus trial. So it was almost statistically insignificant. In the years since 2017, when Ocrevus came on the market, that we have been using it, and it's one of the top used medications in the country right now, most used. We're just not seeing an increase in breast cancer, even though that was in the original information to be sent out to people.
Hmm. Okay, that's really good advice. So Joy, would like to know your thoughts on stem cell therapy.
There's a lot of different kinds of stem cell therapy. HSCT is the one that was most commonly used. We're now starting to do some mesenchymal stem cell therapy. Most insurances are not covering the cost of it. It's very costly. So if you can get into a clinical trial for mesenchymal stem cell therapy, it may be helpful. Um, it doesn't really, with both types of stem cell therapy, mesenchymal or HSCT, they really don't seem to work very well in people that are over 30, 35.
Hmm.
You have to be new to the disease, and you have to have an immune system that's amenable to change. And oftentimes, by the time we hit middle age, our immune system's pretty set in its ways. Um, They're also finding that those stem cell treatments often seem to lose their effectiveness after about 5 years, and people start having a resumption of symptoms. It's an excellent, people that are getting these therapies often have very excellent results, but they are about $500,000 to $1 million a piece for treatment, for a course of treatment.
Okay. Somebody would like to know, I think probably the answer would be yes, but how do you how let me rephrase it actually. How often do you recommend stretching for spasticity?
Every few minutes.
Okay.
I find I work that stretching routine into my day. In fact, as I'm sitting here at my desk, when you asked that question, I was actually pulling my toe up so that I was stretching my calf under the desk. It you just make it a part of your regular work, whether it's, stretching out like so, or whether it's stretching your neck, or uh, anything like that. I mean, you can do a series of stretches. Hold your stretches for a minimum of 30 to 60 seconds because they're not effective if you don't hold it that long. The muscle just snaps right back. So when you're stretching a rubber band and you get that rubber band, if you hold the stretch for longer, the rubber band gets bigger. That's what you want to do with the muscle fiber. If you just pull it out and it snaps right back if you don't hold that stretch long enough. So just think of the rubber band.
And you can kind of recommend that for just about anyone. It doesn't specifically have to be for spasticity.
Right.
Obviously, it's great. It's a great tool for that. But like that just could be utilized for anyone, in terms of just trying to stay loose,
Yep.
right?
Yep.
Okay.
True.
Uh, is Galenia zero point 0.5 milligrams a good medicine for multiple sclerosis? I've been taking it for 3 years. I know it's a really strong medicine and makes me sleepy and my head hurts. Are those side effects?
Those are not side effects of Gilenia, no. So I don't know why you're getting those side effects. And it's not a really strong medicine. It was when it first came out, it was one of the most potent that we had on the market, but it no longer falls into that category because we've got much more effective medications that don't have to be taken daily.
Hmm,
So have a conversation with your doctor and ask them about whether it might be appropriate to change your medicine.
okay. So this is kind of a comment, just more of just like, letting you know more about their situation. So constipation is affecting my life in a bad way. Nothing works, unfortunately. Diet, as recommended. I did try your recommendation of Metamucil capsules, I would imagine, for 3.5 days. Embarrassing flatulence, but no relief. Uh, Bisacodol, needed for BMs. Takes a couple of days to get empty. Nobody knows how to help.
Um, your story sounds a lot like my life. I really, I'm glad you picked up on the Metamucil capsules, 2 to 3 twice a day. Um, they recommend 5 twice a day. So I found that I was getting too much flatulence with that number and it wasn't really working. And for me, that sweet spot was 2 twice a day. I sometimes still need to take that bisacodyl or Ducalox dose maybe once every week or two to just clear things out. But certainly increasing the fiber in your diet, getting away from processed foods, um, lots of fresh fruits and vegetables. Don't overcook your vegetables. Salads are preferable to a well-cooked spinach or something of that nature, for example. So something that you would have in salad, like a spinach, should be as lightly cooked as possible. And with things like spinach, that's 30 seconds in a skillet.
Mm,
So you can soften it, but it doesn't break down the fibers. Um, and things like nuts, um, that sort of thing. Keep away from your breads. Let's see. Tanisha. Oh, wait a minute. That's okay. I just saw something pop up on my screen. I'll let you get that. It's a
yeah, no worries.
Facebook person. Um, you really just need to increase the fiber and the fluid in your diet and play around with the Metamucil. Metamucil is not a laxative. It will not make you go. It will facilitate that emptying. So what I think I would try to do is to take that dose of bisacodyl and then start your Metamucil that day and 2 to 3 caps that day because you're emptying out that load and it's not piling up. It's the flatulence is caused by the piled up stool that's not moving. So you need to liquefy that and get it out.
Hopefully that will get you on the right path. I know that can be very uncomfortable. So wish you all the best. Someone would like to know, I'm on a low dose of gabapentin for nerve numbness. I am concerned though, the effects on the brain as far as dementia. Is there anything else that can be taken as to not affect cognition?
Not really. Gabapentin works for some people for numbness and pain. Other people it doesn't work for. It is fast becoming one of the most abused drugs, most prescribed drugs on the market, and it can be very habit forming.
Hmm.
So it's possible that you just need to talk to your doctor about tapering that dose off. It should help with the cog fog and also help to avoid you getting particularly addicted to it.
That's very true. Tanisha from Facebook asks, I drive long hours for work. I find myself getting sleepy a lot and having spasms while driving. Suggestions, or do I just need to consider changing jobs?
If you're getting sleepy at the wheel, um, that's a real red flag. And if
Mm-hmm.
it's happening more than just on a very rare occasional thing, if it's happening every time you're driving long bits, you don't need to be driving. You're putting yourself and everybody else around you at risk.
Abby would like to know, is strength training a good form of exercise for an MS patient?
Yes, you should alter your strength training and your stretching sessions. So maybe 3 days a week, do strength training, and 3 days a week, do your stretching and movement exercises.
Okay.
So opposite
Okay.
days of the days you take a walk, stretch. I mean, do your strength training on the opposite days that you're walking.
But you should be able to integrate stretching into that, correct? As
Oh
well?
yeah, yeah,
Okay,
yeah,
for sure.
yeah. I mean, if you want to spend a half hour exercising and do 15 minutes of strengthening and 15 minutes of stretching, that's fine. But what most physical therapists are recommending for people with MS is that they focus on one type of exercise. So they do strengthening one day, stretching the next day to give
Mm,
their muscles a rest after strengthening, and then go back to strengthening so that you're not sore all the time, so that you're conditioning those muscles and not over tiring them.
interesting. I did not know that. That's actually incredible advice and information. Thank you, Cherie. Um, Somebody would like to know, first to give you a little context, I'm 67. I've had MS for 30 years, now active secondary progressive MS. Currently taking Copaxone. Is a highly effective DMT too much of a risk of a side effects at my age?
67 Copaxone is the appropriate level of treatment.
Okay.
Um, unless you're still having new lesions. If you're still having new lesions and disease activity, you say you have active secondary progressive, that would tell me the technical term active secondary progressive means you have new disease activity on your MRI. It doesn't mean your disease is worsening. So if you actually have new disease activity on your MRI, you maybe need something more effective than what
Mm,
Copaxone is.
okay. Uh, so somebody's been on, and I pronounced this earlier, but it's Supposia, or is it Supposia?
Zeposia.
Supposia. All right, I got this time. All right, so I've been on Supposia for 3 years. I'm 65. I ask my neuro every time I see him whether I should change meds to a stronger one, and he always recommends that I stay on Supposia. Should I push him harder on my request?
65 on Zeposia. I tend to agree with your doctor.
Hmm. Okay. Sorry, you've been overruled. Juliet asks, could MS be affected by neurogenic bowel and require bowel training, much like people with spinal cord injuries?
Certainly can.
Okay.
Most MS centers, or also spinal cord injury centers, have a bladder bowel therapist on staff. and they work with people with MS as well as those with spinal cord injuries to retrain bladder and bowel, and it can be very, very helpful for people with MS.
Okay, hopefully that answers your question. Folks, I don't see any new questions in the Q&A section. If anybody has any last minute questions or comments for Cherie, this is the time to do it as we near the end of our program. So give everyone another 30 seconds to either raise their hands or get a question in Facebook or put something in the Q&A. If not, then we'll wrap it up. But while we're doing that, Cherie, again, I'm just blown away about how much I learn every single time I'm in a session with you. So I truly appreciate your time and expertise, and I believe everyone in this event says the same thing. We're getting a lot of thank yous from individuals who either ask questions or listen to this program. You are such an asset to us and MS Focus. So on behalf of everyone here, I just want to say thank you so much for doing this time and time again. As Cherie did mention, she will be with a new presentation next month. If you would like to, as I'm about to wrap things up, Cherie, just remind people when they can next see you.
I'll be doing a talk on the impact of hormone changes in women living with MS on May 7th at 3 p.m. Eastern Time. This is a unique month for us. We're giving you our Ask the MS Expert ×4 this month. So you've got me today, you've got Dr. Thrower next week, you've got Dr. Boster the following week, and Dr. Karpatkin in physical therapy the final week of the month. So save your questions if they happen to be rehab related to the final session with Dr. Karpatkin. If you've got other questions that come up, you're more than welcome to send them to me at Cherie@msfocus.org. I do try to get back to you within a 24-hour period of the time that you've sent the email. Sometimes it's a matter of hours or less. So do feel free to email. If you have a question for one of the other folks that are MS experts, I'm happy to forward those questions to them as well.
All right. I try to put this I put it in the chat, but it's still coming up for packing. Just give me a second, and I'll write it in the chat for everyone. Like we mentioned, we are at the end of our time. If you missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Actually, if once we complete this program, it will automatically be on our Facebook feed for people to watch at their own leisure. Reply to your registration email for info on how to access recordings or sign up for our newsletter to learn about upcoming events. Like Cherie mentioned, our next teleconference will be held next Tuesday, April 8th at 4:30 p.m. Eastern, during which Dr. Ben Thrower will once again answer your MS-related medical questions at his bi-monthly town hall Q&A. I actually just was with him at a live event at the Shepherd Center in Atlanta, and I am just completely in awe of the amount of the sheer amount of wealth of knowledge, excuse me, that this gentleman has, and he's so great at being able to answer as many people's questions in a way that's very easy to understand. So I highly recommend you go check it out. As you leave the conference today, a survey will appear on your screen. We kindly ask that you take a moment to provide us with your feedback on this program and share your suggestions for future topics so we can ensure that we provide you with the most meaningful programs possible. Our sincere thanks to all of our attendees for your participation today, and especially again to Cherie Binns, who dedicates so much of her time to helping the Multiple Sclerosis Foundation and the MS community at large. Enjoy the rest of your day, everyone. We look forward to seeing you next time. Have a great, wonderful day. Thank you so much for joining us.